Anesthetic considerations for pediatric electroconvulsive therapy. Electroconvulsive therapy, ECT, is indicated for a variety of childhood psychiatric diseases. General anesthesia is typically administered for this very brief but very stimulating procedure. There are several reports on the anesthetic management of adults undergoing ECT, but a comprehensive review addressing the unique pediatric implications and management strategies is lacking in the general medical literature. Based upon the extensive experience with pediatric ECT at our institution, we hope to provide an overview of pediatric ECT and provide practical recommendations for the peri-procedural management of children presenting for this therapy. ECT was first described in the 1930s as a means to provide a generalized epileptic seizure in psychotic adult patients, and it was subsequently elucidated that the seizure, not the electricity, held the promise of therapy for a wide range of mental illnesses. It has been used since that time in the adult population to treat various neuropsychiatric disorders from critical suicidality to psychosis to less urgent cases of refractory depression or catatonia. Pediatric ECT is typically performed by placing 2 electrodes on specific areas of the scalp and then invoking a generalized seizure by allowing an electric current to pass through the child's brain between the 2 electrodes. The actual exact mechanism by which ECT produces favorable outcomes in certain pediatric psychiatric diseases is unknown, but most theories suggest that major neurotransmitter, neuroendocrine, and neurotrophic changes occur within the central nervous system after a series of treatments. The location of scalp electrode placement influences the portion of the child's brain that the electric current passes through, and the particular placement of electrodes with associated wires may impact the anesthesiologist's ability to properly manage the airway. The pediatric psychiatrist may choose a right unilateral or bifrontal position over the classic bitemporal position to reduce post-ECT language, cognitive, or retrograde amnestic complications in some children. After induction of anesthesia, the psychiatrist delivers a brief pulse of electricity, which is measured in milliseconds at a certain dose to surpass the individual seizure threshold of the patient and induce a generalized seizure. The child's electroencephalogram, EEG, is monitored, seizure activity is confirmed, and a minimal seizure duration of 15 seconds is required to be considered a therapeutic seizure. The first ECT session for a child is often the longest, most complex ECT session, as the seizure threshold and the appropriate electrical dose needed to produce the seizure must be found. Though interpretation of the EEG signals induction and termination of the seizure, some pediatric psychiatrists may wish to observe tonic-clonic movements of an extremity, typically the right foot, to confirm seizure activity. Electromyogram, EMG, may be utilized by placing a right temporal electrode which would correspond to motor movement of the right foot during the seizure. Alternatively, a blood pressure cuff on the right lower extremity may be inflated prior to injection of an intravenous muscle relaxant to allow the psychiatrist to observe tonic-clonic movement of the child's foot. With proper planning and execution, the entire pediatric ECT procedure can be completed within 15 minutes, with subsequent transfer of the child to the post-anesthesia recovery area for emergence from anesthesia. Most children may be treated and discharged on the same day, either to home or, if indicated, to a psychiatric inpatient setting. The number of treatments required will vary considerably based upon the underlying pediatric psychiatric disease and the response to initial ECT sessions. Children with severe neuropsychiatric disorders characterized by extreme self-injury and aggression may require 12 or more treatments, while cases of malignant catatonia have required over 60 treatments. Pediatric ECT is most commonly used today in the treatment of affective, psychotic, and catatonic disorders when conventional medications or behavioral therapies are ineffective. A relatively new application of pediatric ECT is for salvage therapy for children in refractory status epilepticus. Though the paradoxical anti-epileptic effects of pediatric ECT have not been fully elucidated, the ability of ECT to augment GABAergic activity within the central nervous system is likely the mechanism of action. Anesthesia for the child undergoing ECT should ideally provide deep hypnosis, ensure muscle relaxation to reduce injury, have minimal effect on seizure dynamics, and allow for rapid recovery to baseline neurological and cardiopulmonary status. It is vital that the anesthesiologist make sure that appropriately sized bag valve mask circuits to provide positive pressure ventilation during the brief period of apnea should be available, as well as airway adjuncts and age-appropriate endotracheal tubes and laryngoscopes. Appropriate facilities and personnel to recover the child during emergence of anesthesia should be secured prior to the procedure. The decision to proceed with an inhalational intravenous induction of anesthesia for pediatric ECT should be based upon the child's coexisting disease, level of cooperation, and effective anesthetic technique on seizure induction, duration, and quality. Intravenous sedative hypnotic agents have classically been given prior to muscle relaxation to provide brief but potent sedation for ECT. Oral or intramuscular premedication commonly given to the pediatric patient to facilitate parental separation, anxiolysis, or sedation prior to venipuncture may have significant effects on the quality of the ECT. All of this is summarized in Table 4. An oral benzodiazepine such as midazolam is frequently prescribed to children in the pre-procedural period prior to normal surgical procedures, but must be used more judiciously in children presenting for ECT. Benzodiazepines have consistently been shown to decrease the seizure duration and possibly the therapeutic efficacy of both unilateral and bilateral ECT. Low-dose intravenous midazolam 0.025 milligrams per kilogram does not appear to prolong seizure duration over the control, but the ability of this dose to provide adequate pre-procedural anxiolysis is unlikely and may result in paradoxical disinhibitory hyperactivity. Dexmedetomidine appears to be a more effective agent for anxiolysis in the child, and actually 2 studies regarding intravenous dexmedetomidine have demonstrated that this agent may be useful in reducing post-ictal agitation and may slightly increase seizure duration when given prior to propofol. The choice of anesthetic agent to use prior to skeletal muscle relaxation is often debated. The anesthesiologist must understand the effects of various induction agents on induced seizure quality, while also taking into consideration the cardiopulmonary side effects of the agent, the child's comorbidities, and the recovery profile of the chosen agent. The induction agents are summarized in Table 5. Methohexatol is an ultra-short-acting barbiturate that's likely the most commonly used induction agent for ECTs in both the adult and pediatric population worldwide. Methohexatol is a short-acting agent that tends to provide the greatest seizure duration in most studies, and superiority of methohexatol to other agents in the maintenance of seizure duration is clearly dose-related, as a higher induction dosage tends to shorten seizures. Ketamine is gaining popularity as it's very effective as pre-medication for the especially anxious, fearful, or combative child, and it is a second-line induction agent behind methohexatol for ECT, and its properties are clinically favorable for this procedure. Ketamine lowers the seizure threshold and has shown greater seizure duration with increased amplitude when compared to methohexatol. The major drawbacks of ketamine anesthesia for pediatric ECT are hallucinatory effects extending into the postoperative period and prolonged recovery times. Propofol has recently gained greater acceptance as an anesthetic induction agent in adults receiving ECT. Compared to barbiturates, propofol is far more readily available and familiar to the modern anesthesiologist, and there have been more studies that compare its effects to the gold standard of methohexatol than any other agent. Propofol is likely the third-line intravenous agent for pediatric ECT if methohexatol or ketamine are unavailable or contraindicated, provided that the lowest possible dose to produce clinical effect is used. Inhalational induction of general anesthesia with volatile agents is commonly performed for younger children prior to obtaining of intravenous access. Sevoflurane induction for ECT appears to provide adequate conditions for treatment and provides a solid option for anesthesiologists who are comfortable and experienced with this anesthetic technique. Sevoflurane inhalation induction has been compared to methohexatol and propofol intravenous induction in clinical trials, with mixed but overall favorable comparative results in the terms of seizure dynamics and safety. Inhalation induction takes longer to reach anesthetic depth sufficient for treatment and also leads to slightly longer recovery periods. Induction of the electrical stimulus for ECT is followed by vigorous motor seizure activity, which is typically mitigated by administration of a muscle relaxant after induction of anesthesia. Due to the brevity of the ECT procedure, succinylcholine is the most commonly used muscle relaxant for ECT. However, administration of non-depolarizing muscle relaxants may require intubation, a brief period of mechanical ventilation, reversal with an anticholinesterase agent, or administration of sugammadex, which significantly increases the risk associated with this procedure and must be discussed during the informed consent process. Reflective questions. Number 1. What are the most common indications for pediatric ECT, and why is it being utilized more frequently as a treatment option for younger patients? The answer is the most common indications for pediatric ECT are refractory depression, psychotic disorders, and catatonic disorders like catatonic schizophrenia. In addition, some children with aggression or treatment-resistant autism are candidates for ECT. A relatively new indication for ECT is in the management of refractory status epilepticus. ECT is gaining popularity, though it is still only considered when all other conventional treatment options have been exhausted. There is a growing body of evidence for the safety and efficacy of ECT, and so it is being used more frequently as an attempt to restore quality of life to the child suffering with refractory psychiatric disease. Number 2, what are the unique pediatric factors that need to be addressed when planning the anesthetic care for a child requiring ECT? The same basic concept for ECT for adults exist in children, but there are a few notable differences. The issues regarding consent and assent for ECT is very complex and may often require involvement of an ethics board, particularly in cases where the legal guardian gives consent but the teenage patient refuses treatment and the decision-making capabilities of the patient is under question. Premedication is often given to children prior to anesthetic induction, but common agents such as oral midazolam will render an ECT suboptimal. Most children may not need premedication, but those children that are especially challenging may require agents such as dexmedetomidine, clonidine, or ketamine. Number 3, what are the most appropriate pre-procedural anxiolytics and intravenous induction agents for pediatric ECT? These agents are summarized in Table 5 and 6 of the manuscript. Ketamine and dexmedetomidine are likely the most appropriate pre-procedural agents. Methotrexate remains the gold standard for IV induction, but propofol and sevoflurane are acceptable as well. Ketamine is gaining popularity and may provide additional benefits for patients with depression. Question 4. What is the role of inhalational induction of anesthesia for this patient population? Inhalation inductions are typically performed for younger children and is a comfortable means of induction for pediatric anesthesiologists. Sevoflurane is an acceptable agent provided concentrations are kept to a minimal following induction and prior to placement of the stimulus. However, the need for an anesthesia machine and additional monitoring is required when inhalation and anesthesia is utilized, and this may prove challenging in certain settings. So in conclusion, electroconvulsive therapy, ECT, is a safe and effective tool for the treatment of a variety of pediatric and adolescent psychiatric disorders, as well as in the treatment of pediatric refractory status epilepticus. Though not initially used in the pediatric setting, accepted indications for its use have increased steadily over time. Anesthesia for the child undergoing ECT should ideally provide deep hypnosis, ensure muscle relaxation to reduce injury, have minimal effect on seizure dynamics, and allow for rapid recovery to baseline neurological and cardiopulmonary status. Multiple anesthetic agents are acceptable for use during ECT, and the choice of specific agents should factor in the patient's underlying comorbidities and desired recovery profile.